After this lecture, you should be able to recognize the different healthcare plans, differentiate between government and privately funded insurance options, describe the pharmacy reimbursement and adjudication process, identify common third-party rejections, comprehend common reimbursement terms, calculate various values as they relate to reimbursements, and explain the purpose of PBMs and why they are profitable. Starting with healthcare funding, funding for the healthcare system is paramount. The availability of funds determines the structure as well as the quality of the services provided to people. The healthcare system here in the United States is either funded by the government or by private entities. So we're going to talk about government funded healthcare, private entities, as well as patient assistance programs. Starting with government funded healthcare, tax dollars help to provide the funds for these healthcare plans. In 2018, Medicare and Medicaid accounted for $1.3 trillion out of the total national healthcare expenditure of $3.6 trillion. So this just goes to show that government-funded healthcare does contribute to a large portion of the national healthcare expenditure each year. Starting with Medicare, they provide healthcare services for the elderly and disabled individuals. It's funded by federal dollars, and you must meet certain criteria to receive it. So you must be 65 or older, living with a disability, have end-stage renal disease, and then it's also divided into parts, as you can see here: Part A, Part B, Part C, and Part D. Starting with Medicare Part A, this is sometimes called your hospital insurance. It covers inpatient and hospital costs, with inpatient meaning that a patient is formally admitted to stay in the hospital, so the patient typically stays overnight. It also covers skilled nursing facilities, hospice care, and home health. Next, we have Medicare Part B, which may be called medical insurance. This covers your outpatient services, with outpatient meaning that the patient does not need to stay in the hospital for care. The services that are covered under Part B typically include doctor's office visits, x-rays, lab tests, and as it relates to you as a pharmacy technician, durable medical equipment like diabetic supplies and preventative care like immunizations. Then we have Medicare Part C. This is an alternative way to receive benefits, and it's also called the Medicare Advantage Plan. They must provide the same coverage as Part A and Part B, but they may have different rules, costs, or restrictions. It also may include additional services such as dental, vision, wheelchair ramps, shower grips, meal delivery, and even transportation. Finally, we have Medicare Part D. This may be called prescription insurance. It covers prescription medications. Depending on the cost of the patient's medications, they may reach the donut hole or catastrophic coverage, which we're going to talk about in more detail. Starting with the donut hole, so when spending exceeds a certain amount, Medicare requires that the patient start to pay a higher percentage for medications. So in 2020, that amount was $3,820, and then patients had to pay 25% of the cost of brand name and generic medications. Then there's also catastrophic coverage. So Medicare drops the percentage paid for medications after reaching a certain amount. So in 2019, if a patient had already paid $5,100 on medications, Medicare would only require them to pay 5% of medication costs for the remainder of the year. Moving on to Medicaid, this is government-funded insurance for low-income, pregnant, elderly, and disabled individuals, as well as children. It's funded by both federal and state dollars, and coverage varies by plan as well as state. This may or may not cover services such as dental or vision. Then we have TRICARE, which provides healthcare services to active and retired armed forces and their family members. And this is also funded with federal dollars. And just of note, a lot of times patients with TRICARE end up having to use the VA if they are veterans. Finally, we have nonprofits. These are federal funding that's provided to nonprofit hospitals and research institutes. So an example is the National Cancer Institute, which is shown in this picture. Moving on to private entities, these are not paid for through federal or state dollars. They could be employee or private insurance. So these plans are commonly bought either through your employer or the healthcare marketplace. Starting with the health maintenance organizations, these are typically called HMOs. In these, patients must choose a PCP or a primary care physician, and all of your care is coordinated under that PCP. Your PCP has to make a referral in order for you to see a specialist or receive diagnostic services, and the referral must always be within your network. So HMOs are the strictest of all of the plans. Seeing providers outside of your network or without a referral will result in paying the whole bill out of pocket. Then we have preferred provider organizations. These are often called PPOs. You do not need to select a primary care physician or PCP for these. If you see a preferred provider, you will only have to pay a portion of your bill. And if you see an out-of-network provider, you will have to pay a higher cost, but the insurance will still typically pay some of the cost, unlike an HMO. PPOs typically also include out-of-state providers that are considered in-network, in case you do a lot of traveling or need to worry about distance healthcare. Then we have exclusive provider organizations, or EPOs. These are similar to both an HMO as well as a PPO. You do not need a referral to see a specialist, but you are still responsible for paying the full price if you see a physician outside of your network. Then we have workers' compensation. So this is used when a patient has been hurt at work and their company has agreed to pay for the cost of their health care, including medication. So the patient may come in saying that they want to use workers' comp for a prescription, and they'll have specific insurance information for just that prescription. Then we have out-of-pocket. So individuals without health insurance have to pay the full price for their health expenses, including medications. Then finally, we have patients' assistance programs. So these include medication assistance programs and discount cards such as GoodRx. They're often provided by drug manufacturers or organizations to help reduce the cost of medications. Unfortunately, eligibility may be based on insurance coverage or citizenship in these programs. So if the patient doesn't have a social security number, or if they do or don't have insurance coverage, it may change whether or not they're eligible to receive the assistance. Now we're going to move on to pharmacy benefits managers or pharmacy benefits management. These are also referred to as PBMs. They're primarily responsible for controlling costs through the use of online claims, pre-negotiated pricing through pharmacy contracts, documenting reported data regarding drug use, eliminating duplicate or unnecessary claims. They also restrict high-priced medications through a formulary, which we're going to talk about more. They try to reduce pharmacy expenditures while also improving health outcomes. So a formulary is a list of drugs that are preferred for any given plan, and this is plan specific. They're designed by physicians, pharmacists, as well as administrators. If all medications are effective, they will choose the most cost-effective option to cover on the formulary, and this can lead to frustration if a physician prescribes a medication that's not covered by the formulary. Looking at the different kinds of formulary, we're going to start with an open formulary. An open formulary allows patients any covered medication within the formulary. Open formularies have the largest number of covered medications. Next, we have preferred formularies. A preferred formulary entices patients to use preferred medications by offering lower prices, often in a three-tier system. So a three-tier system is one that will provide generic medications at a low cost, preferred brand medications at a slightly higher cost, and non-preferred medications at a substantially higher cost. Finally, we have a closed formulary, most commonly seen with restrictive HMOs, like we said, and like Medicaid. A closed formulary simply will not cover any drug that is not listed on their formulary. So we've listed here some drug categories that are not covered by Medicare Part D, which is one of the most commonly used prescription formularies in the U.S. It includes non-prescription drugs or OTC medications, drugs when used for anorexia, weight loss, or weight gain, drugs when used to promote fertility, drugs when used for cosmetic purposes or hair growth, drugs when used for the symptomatic relief of cough or colds, drugs available under Medicare Part A or Part B, prescription vitamins and mineral products except prenatal vitamins of fluoride preparations, outpatient drugs for which the manufacturer seeks to require the associated tests or monitoring services be purchased exclusively from the manufacturer as a condition of sale, and then barbiturates and benzodiazepines. So as you can see, we have a wide range of medications that are actually not covered by Medicare Part D, and that's one of the most commonly used formularies, not even the strictest. Moving on to formulary restrictions, even though a medication may be on the formulary, there are still certain restrictions as to how some medications may be covered or how the insurance company will allow you to use them. First, we see quantity limits. These place strict guidelines on how many dosage units can be dispensed in a specific day supply. So if a provider writes a prescription with an atypical dosing regimen, it may not be covered by the formulary. An example of this is metoprolol succinate ER is typically dosed every day or daily, so the formulary would only allow for 30 tablets in 30 days. If the provider wrote for twice daily dosing, the quantity limit would cause the insurance to not pay for the claim because they only allow 1 tablet per day. We also see step therapy. So a case where the formulary only allows for the medication prescribed to be covered if the patient has already taken other, likely less expensive medications first. So this ensures that a more cost-effective option has been tried before approving a claim of a more expensive medication. So this is an example of where empagliflozin or Jardiance is prescribed for a diabetic patient. However, the patient has not tried metformin first. So the insurance will not pay for the Jardiance or empagliflozin until the metformin has been used first and they at least tried it. Then finally, we see prior authorizations. This is when a provider must answer a series of questions about a patient's condition, and based on the information provided, the medication may or may not be covered. Most of these medications exceed $150 per month. So a prescriber may write for Repatha for cholesterol, which costs about $450 per month. Before the insurance will pay for the Repatha, the prescriber must send the patient's lipid panel values to the insurance to deem that the medication is medically necessary over a less expensive option like a statin. Now to discuss reimbursement. This is the process by which pharmacy is paid for the medications that it dispenses. It involves both the payment from the insurance company as well as the payment from the patient. So to review some common terms before we dive deeper, first we have copay, and this is the amount due from the customer for a claim. So that this is the amount that they're going to pay when they come to pick up their prescription from you. Then there's benefit. This is the amount paid by the insurance for a claim. So this is what you're going to get from the insurance for that specific prescription. You have deductible, which is the amount the customer must pay per plan year to receive any benefit from the insurance. So every year when the year restarts, the patient's deductible restarts. So you may have a patient that comes in on January 1st to get a medication and it comes out to be $200-300. It's typically because the patient has a deductible that they have to pay prior to the insurance company being willing to pay for anything. Sometimes that's $1,000, sometimes it's $1,500, which means they would have to pay for their medications up until they've paid $1,500 worth, and then the insurance company will start to help them. There's also a premium. This is the amount the customer must pay monthly to have insurance. Then we get into average wholesale price, or AWP. This is the average price paid by a pharmacy to buy a drug from the wholesaler, and it's typically much higher than the actual cost that's paid. Then we have the maximum allowable cost, or the MAC. The maximum the PBM will pay for a generic medication. So there is no standardization in the industry as to the criteria for the inclusion of drugs or the methodology as to how the maximum price is determined, changed, or updated. Now that we've covered those, we're going to start discussing adjudication. This is the submission and subsequent response of a claim to an insurance company. In most pharmacies, this does happen almost instantaneously, and more often than not, the claim is paid and you can move on to the next step. Unfortunately, most technicians do think this is the hardest step. A lot of technicians think this is the hardest step because of rejections. There are hundreds of reasons an insurance company won't pay for a claim. Most often, they could be attributed to an incorrect piece of information being entered during data entry. Sometimes, though, there is nothing the pharmacy can do about it. Other times, it does bring the entire process to a halt. This can be really frustrating for both you and the patient. So the first rejection that you'll see very commonly is refill too soon. This typically means the patient has already received a prescription for this medication within the day supply submitted on the previous claim. Technically, the patient should still have some of the medication remaining. So this would be as if the patient came in 20 days ago to receive their medication and now they're receiving or requesting a refill for 30 more days. Unfortunately, they should still have 10 days left on that refill, so they are not eligible to receive their refill yet, and you would get a refill too soon error. So the patient has two options in this scenario. They could pay out of pocket and go ahead and get the prescription now, or they can wait until the day supply expires and have it filled. So a lot of times insurance companies will give you 7 days to go ahead and fill your refill early. So in this case, the patient who came in 10 days early would have to wait 3 more days until it's 7 days from when he needs it, and then the insurance company would pay for it. If the patient is facing an emergency or some other extreme circumstance, you can call the insurance for an override. Then we have prior authorizations like we just discussed. Consistent with what we discussed earlier, the insurance will not pay for the medication until the prescriber contacts them with a valid reason for prescribing the medication. So the patient has two options at this point. They can pay out of pocket, like we said last time, or they can wait until the insurance hears from the provider and makes a decision of whether to pay for the claim. The important piece of this is that as a pharmacy technician, there is very little you're going to be able to do with the prior authorization process. A lot of times, your extent of involvement is going to involve calling the prescriber's office or faxing them a request to complete the prior authorization, but you yourself and even a pharmacist cannot complete the prior authorization for them. So making sure that you tell the patient that it's really up to their doctor to call the insurance and get that approved. Until then, it is out of your hands. Then we have product service not covered. In this rejection, the medication that is selected is not included on the insurance company's formulary. So the patient has two options. Again, they could pay out of pocket for the medication, or they inquire with the provider about a different covered option. Then we have invalid cardholder ID. This is the final one we're going to discuss. This is typically a result of incorrect data entry or a patient getting a new ID card. You want to verify that the patient's information was correctly entered in the system and that they do not have a new insurance card. If they do, the patient should bring their new insurance card in, or you can call the insurance to verify their enrollment. Next, we'll discuss drug utilization reviews or DURs. Based on the info you entered into data entry, your pharmacy software will run a DUR or drug utilization review at the time of adjudication. The software checks for drug interactions, including OTC medications if they're entered, age alerts for pediatric populations and medications, under and overutilization of medications, as well as therapeutic duplication, so if there's more than one of the same kind of medication on the patient's profile. All of these situations would warrant the pharmacist to potentially intervene and counsel the patient. So if you're getting a drug utilization review or DUR, make sure that you allow the pharmacist to handle it. This is not something that pharmacy technicians are allowed to handle. Now we're going to dive into the calculations section and discuss relevant calculations as they pertain to pharmacy reimbursements. So first we see the brand name pharmacy cost calculations. So pharmacies typically net 12 to 20% of the AWP or average wholesale price of the medication. Assume that a pharmacy was looking to purchase 30 of a brand name drug, so Advocor 520. Its average wholesale price is $205. Also, we're going to assume that every brand name medication comes with a 17.5% average wholesale price discount. So this would mean that AWP minus 17.5% is equal to the cost to the pharmacy. So to determine the cost to the pharmacy, we need to simply multiply the AWP by 17.5%, then subtract that amount from the AWP. So this is how much it would cost for us to buy this brand name medication. Putting this into an example, you have 17.5 times 100, which will give you 0.175. 0.175 times 205, which is the AWP for the medication, gave us $35.88. That's the discount the pharmacy is going to receive. Then we take step 3 and we subtract 205 and 35.88, and we get $169.12, and that's how much the pharmacy would pay to acquire that brand name medication. Now we're going to discuss generic pharmacy reimbursement calculation. So this is how much the pharmacy is going to get reimbursed for the generic medications after they submit the claim. So pharmacies typically receive the MAC, or maximum allowable cost, plus $1 to $3 dispensing fees for generic medications. So we're going to assume that a particular PBM paid pharmacies a generic dispensing fee of $1.80. The pharmacy transmitted a claim for 30 glipizide tablets whose MAC, or maximum allowable cost, is $7.50. So to determine the reimbursement amount, you would add the dispensing fee and the MAC together. So here we see our dispensing fee was $1.80. Our maximum allowable cost that the insurance would pay us was $7.50. When we add those two together, we get $9.30 for our pharmacy reimbursement for this generic drug. Next, we're going to discuss profit margin. This is how much money the pharmacy made off of the sale when compared to the price paid for the medication. So we're going to assume for the last problem with the glipizide that we paid $4.97 for the bottle of the 30 glipizide tablets. All you do for this one is subtract the cost from the amount reimbursed to find the profit margin. So in our last example, our reimbursement cost was $9.30. We paid $4.97 for the 30 tablets, so when you subtract those two, we had a profit margin of $4.33. Then we have the markup rate. This is a percentage representing how much more the pharmacy is selling a medication compared to the cost that it costs to us. So assume that we're selling a medication for $60 and the cost of the medication to us was $48. To find the markup rate, you divide the profit margin by the cost and then multiply by 100. So this one has a few steps. First, you want to solve for your profit margin like you did before. So $60 is what we make, but $48 is what we pay. So that leaves us with $12 of a profit margin. Then you solve for the markup rate, which is the profit margin divided by the cost we pay. So our profit margin was $12. And we paid $48 for the medication. So you do 12 divided by 48, which is going to give you 0.25. And then once you multiply that by 100, you get a 25% markup rate. Then we have the cost per dosage unit. This is the amount that we pay per single unit, so tablet, capsule, etc. So we're going to assume that the pharmacy paid $625 for 1,000 tablets of a medication. To solve for the cost per unit, you're going to simply divide the cost of the medication by the quantity of units that were supplied to you. So in this example, the cost of our medication was $625 and we received 100 tablets. So when we divide 625 by 1,000, we get about 63 cents per tablet, so 0.625 or 63 cents per tablet. So what makes PBMs profitable now that we know these equations and we know the calculations for the pharmacy side? The top 3 ways that PBMs are profitable are owning a mail order pharmacy and enticing patients to have their prescriptions filled exclusively through their pharmacy, such as CVS Caremark. Charging administration fees per transaction, so they may charge 15 to 75 cents every single time that you submit a claim, even if it's rejected. And then discounts through a preferred network of pharmacy. The most profitable of these is owning the pharmacy that you require your clients to use. So some programs require that members use a mail order pharmacy for all of their maintenance medications, which make up 70% of the prescriptions dispensed each year. So this means that you would have to use mail order for your blood pressure medications, chronic pain medications, chronic anxiety and depression medications, diabetic supplies and medications, and then any medication that will be taken for the foreseeable future. Perceptions of mail order pharmacies vary among patients. Some really enjoy them and really enjoy the convenience of having it mailed directly to their home. Others struggle with the lack of counseling that's typically offered with them, as well as the difficulty that may happen with the mailing system and receiving their medications. In summary, healthcare plans in the United States can be divided into government funded and private funded sectors. Healthcare plans use PBMs to remain cost effective while still offering the best therapeutic options to patients. PBMs also use a formulary to decide what medications they're going to cover. Medications may be rejected in the pharmacy for a variety of reasons, and calculations can be used to determine the cost of a drug, how much a drug will profit, and more. Finally, PBMs remain profitable through mail order pharmacies, administration fees, and using a preferred network of pharmacies.